And that's really exciting to hear about all the new initiatives that the MS Society has going. And some of those things I'm going to be touching on tonight, or at least are relevant to what I'm going to be talking about tonight. And I'm going to try to talk largely about research that we're doing here in Atlantic Canada, or collaborative work that involves us from across Canada, because it's important, I think, for people to understand that we are looking at these issues that are hopefully important to you here locally. But keep in mind, you guys are the experts. You know, you can talk about how much research I've done and things like that, but you guys are the experts. You're the ones who know about MS more than I do. What I'm going to tell you today, or what I'm going to talk about today, is largely based on a project that we have going that involves multiple centres across Canada. It's referred to as the Epidemiology and Impact of Co-morbidity on MS in Canada project. Involves centres in University of British Columbia, in Alberta, at Manitoba, in Quebec, and here in Atlantic Canada, in Nova Scotia specifically. What I'm going to be telling you is probably things you already know. Okay. What I hope to convey to you is sort of the importance of some of these issues that in terms of how important it is for your daily lives, how important it is, and what we're coming to understand about the importance of some of these issues for you, the people who have MS and who are living with MS. So, one of the questions that Monica said I should address is, what can you do? What can you do about MS? What can you do personally? So, this is easy for me to say, not easy for me to do, okay? Not easy for you to do. Pretty simple. Things that you already know. Eat right, exercise, have a good sleep, pace yourself to manage fatigue. Take control, okay? Take control of MS. Advocate for yourself. Recognize and seek help for the health problems that you have. Use available treatments. Medications only work if you take them. And use your social supports and stay socially and mentally active. Okay? Sounds simple, not easy, I know that. But this is advice that we give really everyone that we come across in the clinics that I work in. And that certainly includes individuals with MS, but it's not limited to people with MS. This is common sense. I know this stuff already, right? I'm going to try to tell you a bit about why this is important. And I wish that screen was a little bit closer, because I'm going to have to turn to read my slides now. Pardon me if I look away. Okay, so this is the disclosures part of it. Our funding comes from Canadian Institutes of Health Research. Some of it's come from the MS Society of Canada, as well as I'm funded also from the Capital Health Research Fund for some of the work that I do. In the past, I've had lots of sponsorship from industry partners, none of which is really relevant to what I'm talking about today. So, some of the things you already know. We have lots of MS in Nova Scotia. You know that we actually are finally getting ways to find out exactly how many people have MS in Nova Scotia by linking our clinic database with the Department of Health administrative database and finding good ways to identify who in the population actually has MS based on the billing codes that the doctors submit. Sounds like we should be able to do this, right? But so far, actually, it hasn't been so easy. And it's not something that's easily done from one province to another, where all of the billing codes and the administrative procedures are entirely different. So we're trying to figure out a way that we can do this at a national level that's consistent across jurisdictions. It's a wonderful thing about Canada, where everybody in each province does something completely different, and we don't talk to each other terribly well. We're trying to solve that, at least from the standpoint of figuring out MS and some of the associated problems with MS with the project we're doing. We estimate at least 2,000 people with MS in Nova Scotia, at least 200 per 100,000 based on the data that we have available, and that is probably rising. More people are coming to the MS clinic. Again, something you already know. When I started back around here, that was when the clinic was Dr. Murray and Pauline Weldon, and some of you may remember those days. Obviously, there's been a tremendous increase in the number of people with MS coming to the clinic, and when treatments became available, guess what? Lots more people started coming. The MS clinic today is an extremely active clinic with an awful lot going on, including research studies that many of you have participated in and contribute to, including the ones I'm going to be talking about tonight. So what I'm going to focus on tonight largely has to do with comorbid medical conditions. What's a comorbid condition? It's just another health problem that people with MS have. Okay? And there are many. What we're trying to find out is, are some conditions more likely to happen in people with MS? Are they a consequence of MS? Are they associated with the progression of MS? Do they make MS worse, or do they make it progress faster? Are they modifiable? And what can we do about that? So let's start with some common vascular, we would call them stroke risk factors, vascular conditions. What about diabetes? What about high cholesterol, high blood pressure, ischemic heart disease? I'm going to show you some data that's come from Manitoba. This is Dr. Ruth Ann Mary, one of my collaborators and the lead investigator on this study. We're replicating these data currently using Nova Scotia data, and doing that also, as I said, in Alberta, Quebec, and British Columbia. So diabetes is not more common amongst persons with MS than in the general population. But guess what? It's increasing in both populations. High cholesterol, same thing. Not more common, but increasing pretty dramatically. High blood pressure, same thing. Not more common amongst people with MS, but it's going up in the population. In this slide, it's broken down by age group, and this is all women. So young women, middle-aged women, older women. So in this case, again, to some extent, increasing ischemic heart disease is increasing with age, as you can see here. Not so much increasing over time, but more so with the older population. But again, not different between people with MS and the general population as a whole. Okay, so we can just forget about these vascular risk factors, right? It doesn't differ between MS and the general population. No, it's important. All of these vascular comorbidities are increasing in the population as a whole, okay? And that includes people with MS. These vascular comorbidities are more common as you get older. That's true of all of them, although I only showed that to you on one slide. And we're not getting any younger, okay? In Nova Scotia, in particular, we have a significantly aging population. That reflects a number of things: out-migration of younger people and just aging in place. A lot of people like to stay in Nova Scotia. Between 1990 and 2010, so over a 20-year period, the population of Nova Scotia went up by 24%. But the population, or the number of people over age 80 in Nova Scotia went up almost 200%. Okay. So this is scary, okay? I work in geriatrics a lot. One of the, as Dina mentioned, one of the things that I do is neuropsychology, and that has to do with cognitive testing for people who have cognitive problems. Some people with MS come to see me because of concerns about that. I do a lot of work in differential diagnosis of dementia and Alzheimer's disease. So, yeah, this is an area that I know a lot about, and the aging population is a big concern, okay? It's certainly big in Canada. It's particularly an issue in Nova Scotia, and worldwide, of course. It's a real significant problem. So vascular conditions are important for people with MS just because people with MS, like everybody else, are getting older, and there's more older people in the population. Here's just another slide to show that. Here's diabetes, high cholesterol, high blood pressure, in 3 different age groups for people with MS. And again, you just see these increases that are going on in the population as a whole. Okay, so that would be just part of the equation. But we also have data, and again, this is from Dr. Ruth Ann Mary, and this is based on a survey, an online survey of individuals, largely in the United States, called the NARCOMS Registry, people with MS who report on a number of things on a regular basis. And one of the things that she was able to determine from these data was that, on average, people with MS who have any vascular comorbidity, any vascular condition, show a more rapid rate of progression, okay? And I don't want to be alarmist about this, but this is on average, and this is a large group of people. It's over around 3,000 people. But you can see a definite difference in terms of how many years you go before developing mobility problems. And there's a significant difference in the number of years, which is on this axis here, between those with a vascular problem and those who don't. Okay. Now, how well that really translates into, larger studies and population-based studies where we can be confident that this is a really true and generalizable finding, it's difficult to know. But again, it raises concerns. Okay. Let's talk about some other conditions, or have a look at some other conditions, which again, I'm going to show you some data from Manitoba, but we're looking at this also in Nova Scotia as well, and across Canada. So chronic lung diseases, asthma or a chronic obstructive pulmonary disease. Seizure disorders, epilepsy, irritable bowel syndrome, and inflammatory bowel disease. And please don't ask me to explain the difference between those two. This is a syndrome. There's not identifiable disease in these individuals, and again, this is much more common, but both of these are, again, bowel disorders. Migraine, okay? So quite a mixed bag, lots of different stuff. What about those conditions? On the top here is just a slide showing people with MS, and this is the general population. And chronic lung disease, it's broken down into 3 different age groups as well. These don't always follow the trend of increasing in frequency or in prevalence with increasing age. All of these, they differ. But chronic lung disease, it doesn't differ between MS patients and the general population in terms of how frequently that occurs. Epilepsy, not too common, but it is more common amongst people with MS. Okay? Something to be certainly aware of. This irritable bowel syndrome, more common in people with MS than in the general population. Irritable bowel disease, much less common, period, but it actually is a bit more common in people with MS. And migraine, pretty common, but more common in people with MS than in the general population. So let me just go back to this for a second. So there are a bunch of different conditions here. There are different patterns. Some conditions more common, these ones, some no difference. But in general, you can see that there are many situations in which these conditions are more common amongst people with MS. Let's look at something a bit trickier, fibromyalgia. And I don't know what you know about fibromyalgia. A lot of people probably know a lot about fibromyalgia. It's a really tough condition to pin down. Physicians have a heck of a time with this, and a lot of them just don't want to talk about it because they really don't know what it is. So it's a really difficult condition to pin down. It's unknown cause. It has widespread chronic pain involving multiple tender points across the body. And people with fibromyalgia will have fatigue, sleep problems, depression, and poor quality of life. Sound familiar? A lot of overlap with symptoms of MS. Okay, so that's what makes it difficult for physicians often to sort of disentangle these things. And it gets tricky to find out, figure out whether this is something that is more common in MS. Are we looking at overlap in symptoms, misdiagnosis, and this sort of thing? But when we look at just billing codes, so what the physicians bill for when they put on their codes on their forms that they fill out for the Department of Health, and we just look at those data, in MS patients versus the general population, fibromyalgia is much more common. Okay, so again, what does that really mean? It's really hard to tell because, again, those are overlapping symptoms in some cases. Is it that people are misdiagnosing MS as fibromyalgia sometimes? I don't think so. But it does raise a number of questions, okay? Things that we need to look at more, and things that we haven't really looked at in sufficient detail yet. We do know, knowing about other health conditions, both common ones and uncommon ones, okay? Knowing that some are more likely with people with MS raises some important questions. So again, are these just consequences of MS? Is the fibromyalgia symptoms, do they come about because of the MS? Is it just overlap? Is there some common underlying cause? And if so, can that help us identify new treatments? So for example, things like, again, inflammatory bowel disease, inflammatory conditions affecting not the central nervous system, but the periphery. Does that somehow have implications for inflammation affecting the brain? Okay, these are things that we can start to look at once we understand these associations between different diseases a bit more. I think more importantly is, how does this affect the lives of people with MS? So with the announcement that Dina made about the surveys, what's important in terms of your quality of life? What are the things that are affecting you? What are your concerns? These are things that are important for you to tell the society about, okay? And keep in mind these other conditions that might also be affecting your life. These are things that we need to know, and it's things that have been largely, I don't want to say ignored, but I think under-recognized for a long period of time. So what can we do about it? And by we, I don't mean me, and I don't mean the doctors in the clinic. I mean us together. I mean you, people living with MS, and the people in the clinic who are trying to figure out what should we be paying attention to and what should we be doing, trying to do something about. Okay. So this is part of what these looking at some of these conditions will help us do, is identify questions and hopefully bring some things to your attention that you're going to bring up to tell us that you got to be paying attention to this. This is important to me. So I've been talking about these physical comorbidities, physical illnesses, so to speak. What about mental health problems? And this is something that we've been looking at really in the clinic, and I'll talk about sort of quality of life and what that means a bit later. But there are issues that we've been looking at, I think largely thanks to Dr. Jock Murray's emphasis on looking at MS patients as people and not a disease that goes back to when he started the clinic. I mean, we've been trying to focus on these sorts of issues for quite a long time now. So mental health problems is certainly something we've been looking at. And you'll see these days lots of reference to depression in particular as being quite prevalent amongst persons with MS. And you'll see figures quoted typically around 30 to 50%. What does that mean? In community-based clinic sample, for example, in Toronto, Anthony Feinstein, who's now the Medical Advisory Committee Director for the MS Society of Canada, psychiatrist, did a study looking at depression in the clinic sample there. It was about 36% of people in the clinic had depression based on quite rigorous criteria. In Calgary, slightly lower. This is an earlier study. Scott Patton, another psychiatrist and epidemiologist who's worked with us, reported about 23% prevalence. But lots of people get depressed. Is this any different than the normal base rate, so to speak, for the population as a whole, is the question. And yes, it is. Again, this is work from Scott Patton based on data from Statistics Canada using the Canadian Community Health Survey. And across different ages, MS versus the general population, depression was consistently more common. Okay. This is why we should be concerned about the government cutting back on Statistics Canada funding. Okay. This is important stuff. Things like the registry will be helpful, but unless we can make some comparisons across with the general population, we're going to miss out on some of these data, and it makes it harder to lobby for services. And if you're not able to say, well, for our population, for our the people who we're caring for, this is an issue. So sorry, that's my plug for Stats Canada. Much as I'll complain about Stats Canada at other times, believe me, but it's important that we have their data. So what about anxiety? Everybody talks about depression, and you could say, well, sure, I'd be depressed if I had MS. That was the usual thinking, honestly, years ago. It was depressing, actually, what the attitude that people had towards that. But anxiety is another issue that's really important. And it's been much less studied, and something we have looked at here and has been looked at again by Anthony Feinstein in Toronto, about 35% lifetime prevalence, 2/3 of whom also had depression as well, had a significant anxiety disorder. One of the things that Cooley Potter, who's a psychiatry resident working with us here in Halifax, noted that a lot of the people that she was seeing with MS had real concerns about being out in social situations, and this was limiting their activities, and they weren't going out and engaging in social activities because of the worry and the anxiety that it provoked. So we looked at that. She had a questionnaire that we could use to evaluate social phobia, social anxiety. And we used that in 245 people coming through the MS clinic here. And we found social anxiety was just as common as generalized anxiety, and they were actually dissociable. It wasn't that if you had generalized anxiety, you necessarily had social anxiety or vice versa. And they were actually more common than depression, using a similar kind of scale for both anxiety and depression here. So social anxiety, big issue. And nobody had really looked at that specifically before. Why is that important? It was 5 times more common amongst people with MS than it is for the general population of Nova Scotia. Again, actually, we had Statistics Canada data for the general population of Nova Scotia on social phobia, and we were able to demonstrate that. It points out that clinicians need to recognize that significant symptoms of anxiety are common amongst people with MS. Okay, maybe there's people who aren't here tonight because they've got social anxiety. And you don't know that, of course, unless you actually go out and ask, and it's not always something that's going to come to mind very easily for people in the clinic. And you know how busy the clinic is, and you know that there's only a certain number of things that you're likely to get through when you're talking with the doctor. So, some of these things have been pushed down to the bottom of the list quite often and don't get brought up, but they're important. Physical disability wasn't associated with anxiety. Physical disability as rated in severity by the neurologist. That's not to say it's not important in terms of being a source of the anxiety symptoms, but just as in general, the way that neurologists rate severity of disability wasn't the basis for anxiety. And anxiety was associated with poor quality of life, as reported by people with MS. And I'll come back to this poor quality of life issue in just a bit. Again, going back to, these are Manitoba data again, something we're going to look at again in Nova Scotia. But mental health disorders, aside from schizophrenia, in general are more common amongst people with MS. And that's whether you take sort of a grand total of everything or a bunch of any kind of mood disorder, specifically depression, specifically anxiety, or even bipolar disorder is more common in MS than in the general population. Okay. That overlap's important. Again, this is not simply, I'm depressed because I have MS. There could be common underlying etiological or causal factors here, one way or the other, and we don't always know which direction it goes. Okay, but we can try to figure that out and see what those associations are, and try to understand what we can do about those. Okay. So, how do comorbidities, how do these other conditions affect health-related quality of life in people with MS? And that's something that we're looking at with your help. You guys have probably participated in, how many people have been to the MS clinic? Hands up? Yes, okay. So you guys have helped us figure this out, okay? When you go to the clinic, you fill out questionnaires and you think, oh my God, not again, the same questionnaire. Why am I doing this? Thank you for doing it. It's important. We're actually trying to figure some things out, and I'm sorry that we're not very good at telling you everything we're figuring out all the time, but believe me, we are doing something with these data. Okay, so we talk about quality of life. The term quality of life gets brought up a lot. What does it really mean? And it means lots of different things. It means different things to different people. What's important about quality of life is you need to understand what people are talking about when they use the term. I was talking about quality of life. So what we say we care about it, what do we mean by it? And you do have to really pay attention to what people are talking about when they use this term, because it does get tossed around a lot without being very well defined. So, I'm a psychologist. We measure things. We pay attention in excruciating detail to how you measure things, but you can ignore all that. Just make sure that people do define it for you. It's multidimensional, includes core domains, usually physical, psychological, and social well-being. But it can reflect spirituality. It can reflect economic situations. It can be a lot of different things. So again, surveys about your quality of life and what's important to your quality of life. You don't have to necessarily conform to what someone else's views are about that. Make sure that you let people know what's important to you in terms of your sense of quality of life when these kind of surveys come out. For our purposes, what we focus on is health-related quality of life. Okay, And that's really the perception and evaluation by the patients themselves. That means, by you, by me, when I'm a patient, of the impact that a disease causes on their lives and the consequences of that. This is arguably the most important endpoint for medical care, okay? Because really, what should matter other than how you feel about your health, right? Do you feel good about your health? Do you feel really bad about your health? I think the target should be health-related quality of life in terms of all medical care. What's your LDL? I don't know what LDL is. It's something to do with cholesterol, and it's good cholesterol, bad cholesterol. I don't know. I can't tell when my cholesterol is up or down. I have no idea. So telling me what my LDL is, and isn't that great? And don't you feel good about that? I don't know. But I know when I feel good, and I know when I don't feel good. Okay. So so we do use these kinds of things, and it's important to ask people. Okay, what do you feel about your quality of life? And we've been doing this for a while. We do, again, take a pretty narrow perspective, and the instruments that we use really focus on the health part of it, not so much some of the other things that are certainly important, but it's just not something we can necessarily do much about or control. So we use something called the Health Utility Index Mark III. The advantage of this, again, it's used in a lot of national surveys, okay, and it's useful across diseases. You can get into discussions about whether you should use things that are specific for a particular disease or general. We've gone the route of taking an instrument that can be used across a variety of diseases, and it's used in national surveys, so we can make useful comparisons with people in the clinic and, in this case, in our study, with the population as a whole. We've been also looking at mental health symptoms using a scale for anxiety and depression in people who are coming to the hospital who have medical illnesses. We're looking at fatigue. It's not covered in this particular index, which does look at mobility, dexterity, your use of your hands, vision, hearing, but also, importantly, pain, cognition, and mental health. Again, just anxiety, depression. But fatigue is not covered, and we know that's a really important symptom of MS. So we measure that with another scale that we developed here actually many years ago. And the Expanded Disability Status Scale, or the EDSS, is what the neurologists use to rate neurologic disability in the clinic. And that's meaningful to them. Maybe not so much to anybody else, but to them, they know what they're talking about. And we're asking people to tell us about comorbid conditions. And we've looked at which ones people can actually report fairly accurately, and we have a scale or a questionnaire that looks at those. These are some of the comorbid conditions we've been looking at. You'll notice I'm just highlighting a few which are the mental health conditions, but depression, that's the highest one that people report. Have you ever been diagnosed by or been told by a doctor you have depression? Pretty high, quarter of people in the sample of 400 that came through. Anxiety, again, pretty common, and lots of other things that probably follow pretty much, the population in terms of, migraines. I got 16%. We had a show of hands around the clinic, and actually it's much higher amongst people in the clinic and the researchers who have migraines, but there you go. Anyway, cholesterol here at 12%. I'm not sure how these stack up, but again, these are self-reported, and what we're doing is actually looking through, by linking with the Department of Health billing databases and looking at codes that get put in there in an anonymized way. We can actually look at what is the true, if you want to call it true, prevalence of these conditions. Okay, so we've tried to look at what contributes to quality of life as we measure it using this instrument. And this is where the fancy math comes in that my postdoctoral fellow, Lindsay Berrigan, has been working on. So this is just a sort of quick run-through and arguably an early or preliminary version of this. So we look at effects of disability status on health-related quality of life. This is your neurologic disability as rated by the neurologist. Self-reported symptoms of anxiety and depression. We know those have an impact on your health-related quality of life, and we know fatigue does. And we also know that these can have anxiety, depression can result in fatigue, disability can result in fatigue, and that in turn can affect your quality of life. So we're looking at relations amongst these things. We're also looking at these comorbid medical conditions. In this case, we've taken out the anxiety and depression from the comorbid conditions here, looking at the other physical health conditions. And we're just kind of adding them up. How many do you have? 1, 2, 3, 4, none? And we know that these can have comorbid illnesses can have their effects by contributing to anxiety, depression, contributing to fatigue, and again, contributing to quality of life. And taking into account things like age, sex, course, duration, all of those kinds of things too. And these are numbers that are really unimportant, but all we're showing here is that these have significant associations when you look at them independently. And this has been shown lots of times, okay? We know that more disabled, lower the health-related quality of life, more fatigue, the lower the health-related quality of life. If you've got anxiety, depression, lower your health-related quality of life. Lots of people have done this numerous times over the years. There's also these indirect effects on fatigue, and what you end up with is, I always have trouble saying this, but the total is more than the sum of its parts, okay, when you look at these kinds of relationships, okay? So when you add all these things up together, it's more than just looking at the direct effects alone. And we've done the same thing looking at comorbid illnesses. On their own, they don't account for an awful lot of the variance, if you like. It doesn't lower your health-related quality of life an awful lot if you have more comorbid illnesses, but when you start looking at how comorbid illnesses affect anxiety, depression, how they affect fatigue, and in turn how that affects health-related quality of life, comorbid illnesses start to be pretty darn important. They start getting up there with fatigue alone or with depression, anxiety alone, okay? So what I want to illustrate to you here is that, you can look at any one of those and say, diabetes, does it affect health-related quality of life in people with MS? And you'd probably say, not so much, it's not a big deal if you just look at it on its own. But once you start putting these things together and you start seeing how they're interrelated to each other, you can begin to see that these things become really important, okay? And they really do contribute to how people rate their overall quality of life. But you've got to look at some of the things in between, the steps in between, and the way that some of these other medical conditions are going to affect your health-related quality of life. Okay. And that's probably just what I just said. Right? Okay. So neurologic disability, yep, that's really important, okay? Anxiety, depression, yep, important. Fatigue, all important. Comorbid illnesses directly, not so much, but the indirect effects cause worsening of anxiety, depression, and add to fatigue. And then all of these are modifiable, potentially modifiable risk factors or effects, okay? We can do something about that if we target these things to try to improve quality of life. So we can do something about your diabetes, your high blood pressure, your high cholesterol, okay? Comes back to this common sense stuff, all right? What can you do? Well, you can eat right, you can exercise, you have a good night's sleep, pace yourself to manage fatigue, okay? You take control of things and say that, MS doesn't control me, okay? I'm in control. There are things that I can do. You can advocate for yourself and you can get the services that you need, okay? You need to recognize and seek help for these other health problems. They're not something to let slide, okay? It's not something you should ignore. It's something that you do need to talk to your doctors about, and your healthcare team about. It's something that can be important in terms of improving your quality of life or stopping it from getting any worse, okay? Again, use available treatments, and I'm not talking about just MS treatments here. I mean any treatments. The compliance rate for things like blood pressure pills and cholesterol and things like that. Again, if you don't notice the symptoms, then you tend not to take those medications. Medications where they cost money, they don't make you feel better. It's tough to keep taking them, but they only work if you take them. So it's important that you use the medications that are going to be important, that are going to be helpful in treating some of these other conditions. And then use your social support. Stay socially and mentally active. That's a key, okay? I'm just going to show you a couple more things. This is work from Michelle Plowman, who's a former postdoctoral fellow with me. She's at Memorial University in Newfoundland. These are a couple slides from a qualitative study she did based on interviews of people with MS who were over 55 and had MS for at least 20 years, many of whom had not had any disease-modifying drugs or had never had the opportunity to use those. But she looked at their path, their experience with living with MS and some of the things that they went through. And some of that would change, of course, with there weren't MRIs when a number of these people were first diagnosed, and that has changed the speed with which people are diagnosed quite a bit, obviously. So, but you looked at what are the issues that led from, initially wondering what the heck is going on, that struggling and searching for answers, to getting a diagnosis, through to the process of accepting, okay, this is MS and this is what I'm living with. And there were a number of stages and people took different paths to get there, but once you got to the level of acceptance, you could get into the mode of moving towards self-management, okay, taking care of yourself. And a number of the things that were important there were really gaining knowledge and confidence about your condition, about MS and what it means, hopefully through useful interactions with healthcare providers about what that means. Developing strategies to stay healthy, and this is what I'm talking about, that self-management, okay? And then integrating that sense of MS with yourself. So MS, again, MS doesn't control me. MS is what I have, but coming to an acceptance of that and dealing with that, very difficult thing to do, and it takes a long time. It's not something that happens overnight, okay? We understand that. But once you get to this point, then there are things that you can do to begin to manage MS on your own, to take control and start managing it. This is a model that Michelle developed based on the interviews that she did, and this is something that she's pursuing now. There's a national level survey that she's developed, and some of you may have gotten that information. And this is really, really important. It's rolled out at, as I said, a national level. She has information back from over 600 people last time I spoke with her, and she'll have more than 1,000 people. This will be the largest survey of its kind ever in the world. She identified a number of foundational factors, as she put it. Things that are really important in terms of healthy aging with MS. So things like social supports, financial flexibility, maintaining good mental and cognitive health, and resilience, your ability to go with the flow, manage things when they're thrown at you. All of these things interact, and she considered them sort of foundational factors. The more critical proximal factors, things that are more directly related to how are you doing currently as far as aging well with MS, include things like maintaining work or social engagement, having effective and accessible health care, again, maintaining healthy lifestyle habits, and maintaining independence at home. Okay? All of these things, again, you can find reasons why these are all difficult, but they're all things that, to some extent, you can exert some influence over yourself or seek help to do. And clearly, these are things that are going to be influenced by all of these foundational factors. But again, if you don't have the financial flexibility, maybe you have some social supports that will support the deficiencies in this area. So, these are just areas that she's exploring currently with the survey that she's got out, to look at how these things all interrelate and what can lead to best healthy aging with MS. Okay. And I'm just going to end by thanking or acknowledging all the people who have contributed to the work that I've been talking about today. So there's a team of us involved with the epidemiology co-morbidity project. Dr. Ruth Ann Mary in Winnipeg, Scott Patton in Calgary, Helen Tremlett in Vancouver, Tina Wolfson in Montreal, Sharon Warren in Edmonton, Lindsay Berrigan, who's working with me here in Halifax, and Michelle Plowman, as I mentioned. All the folks at the Dalhousie MS Research Unit, which is all of those people. And the funding has come from the Canadian Institutes of Health Research, the MS Society of Canada, and some of the work that from Dr. Mary came from the National MS Society in the U.S. And that's it for me after our next presentation. So thanks very much.